Very good evening to all. Respected moderators of the day, Dr. Suresh Kumar sir and Dr. Varghese Chacko. The eminent speaker of the day, Dr. Ashwin P. Rao. So we are continuing, good evening to all, and we are continuing the third session. That is, yesterday we couldn't do it because of the lack of time. So we are continuing the third session, the pharmacological behavior management by Dr. Ashwin P. Rao. So welcome you all to this program. So over to Dr. Suprasid for introducing our speaker, introducing our moderators.
Thank you, sir. Good evening, all. Our first moderator is actually last day's moderator, Dr. Suresh Kumar, sir. Welcome, sir.
Thank you.
And our second moderator is Dr. Varghese Chacko. Sir completed his BDS from Courts Manipal and MDS from GDC Trivandrum. After that, sir joined in Ramachandra Dental College, Chennai. Later, he worked in PMS Dental College, Trivandrum and in Courts Manipal. He has many scientific publications in his credit. He has his own exclusive pediatric dentistry practice in Trivandrum. Varghese sir is currently working as professor in Sri Shankara Dental College, Varkala. Welcome to the program, sir.
Thank you.
Sir, over to you, Suresh sir, for introducing our today's presenter, Dr. Ashwin Rao, sir.
Thank you. Dear students, postgraduate students, today we got only one session. Yesterday we couldn't complete it because of lack of time. The speaker is Dr. Ashwin P. Rao. He is currently working as associate professor, pediatric dentistry department for MCOTS, Mangalore. He got many awards and credits to his name, but with his permission, I am restricting his achievement list to 3 points, which will be interesting to you as postgraduates. First is, he took post-graduation MDS Pediatric and Preventive Dentistry from Manipal Academy of Higher Education in 2005, and he was the best outgoing postgraduate student. Second point, he was awarded Best Teacher by Manipal Academy of Higher Education in 2 years, that is 2013 and 2017. Third point, he got a lot of publications, around 33 national and international publications to his name. Dr. Anandaraj and Dr. Suprasid has rightly entrusted this part of behavior management to Dr. Ashwin because of his fondness to IV sedation techniques and special liking to midazolam sedation. He did many presentations in conferences and in other platforms. I also feel he is the apt person to take this review class. Best outgoing postgraduate student, best teacher, many publications, and of course, fond of this topic and presented in many platforms. I'm over to Ashwin P. Rao.
Thank you so much, sir. At the outset, let me thank the Association of Pediatric and Preventive Dentists, Kerala, for this wonderful opportunity to interact with students. And I'm very happy that my very dear friend, Dr. Varghese Chacko, is here. We were colleagues in MCOTS for many years, and he's a very well-gifted clinician and academician, and I've learned a lot from him. And it's a privilege that I'm able to do this presentation in front of him. So here I go. The screen is visible?
Yes, sir.
All right. So today I'm going to talk about moderate sedation, deep sedation, and general anesthesia. So postgraduate students, this is the business end of your, I'll just put my timer as well. So it'll be a short presentation within 45 minutes. So this is the business end of your postgraduate course. So this is what we call as the slow goers of your postgraduate course. So since these are your slow goers, you're already under a lot of pressure preparing for your exam. So I'm not going to complicate things for you any further. So this is going to be primarily an exam-oriented presentation, and my intention is to simplify the subject of moderate sedation, deep sedation, and general anesthesia for you. So since you're EGPGs, I expect all of you to have a sound foundation in these three topics already. So I'm not going to go into the nuts and bolts of each topic. So the flow of the presentation is going to be like this. I'm going to explain the basics of these three topics to you. Then we'll take on a few questions that have appeared in the previous university exam papers on these three topics. And then I'll give you references to help you prepare an answer for the questions that have been asked. So that's going to be the flow of the presentation. So here we go. So conscious sedation. Now, as you see on the screen, this question has been asked as a short answer and as a long answer in various university exam papers. These are actual questions which have been asked. And the question has been asked in various combinations, permutations, and combinations. So it's a very common question. Now, a common mistake which is made by postgraduate students is they think that conscious sedation is equal to nitrous oxide sedation only, which is not the case. Conscious sedation is actually old terminology for what you now know as moderate sedation. So the definition of moderate sedation as given by AAPD confirms this. So here they say that moderate sedation, the old terminology is conscious sedation. All right, so first let us understand the basics of moderate sedation. So here I underlined certain important parts of the definition through which we'll try and understand what moderate sedation is. The first part I've underlined is conscious sedation. So that basically means moderate sedation are techniques where the patient always has to remain conscious. So the minute the patient becomes semi-conscious or unconscious, that is no longer moderate sedation. So moderate sedation techniques are conscious techniques. The second part I've underlined is patients respond purposefully to verbal commands or after light tactile stimulation. No interventions are required to maintain a patent airway. So now this basically means, suppose you're working on a child under moderate sedation. Let's say you have administered oral midazolam to the child, and the child slowly drifts away to a light sleep in between the procedure, and you see that the saturations, there's a minor desaturation, let's say 95, 94. So in this case, according to the definition of moderate sedation, you only have to tap the child and call out his name, and that should be sufficient for the child to wake up and regain his muscle tone and spontaneously ventilate well, and then the saturation should go up on their own. So the definition is very specific that no interventions are required to maintain a patent airway. So when the definition says intervention, that includes even the most basic intervention. That is, even if you are in a position where you need to do a head tilt chin lift for the child to bring back the saturation, that means purely under the definition, you're no longer under moderate sedation. The child is slowly drifting towards deeper levels of sedation. So under this definition, strictly no intervention should be required, and a light tap and calling out his name should be enough for the child to just wake up, regain his muscle tone, start breathing, and whatever minor saturations are there should go up on their own, along with maybe a little bit of suctioning of the throat. All right, so that is very, very important part of the definition that you should understand. Then the last part of the definition, the drugs and the techniques used should carry a margin of safety wide enough to render unintended loss of consciousness unlikely. So this means the drugs that you use in moderate sedation should never, when you give them in prescribed doses, should never ever lead to unconsciousness. So that is why the moderate sedation drugs are different from deep sedation drugs. Some examples of moderate sedation drugs are midazolam, hydroxyzine, chloral hydrate or triclophos, And like yesterday, Dr. Sunil comprehensively and beautifully discussed nitrous oxide oxygen, which is a part of moderate sedation. So these drugs, when you give them at prescribed doses, will never lead to unconsciousness, except maybe in a very, 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 very rare case of a hyper responder, which is, they are outliers. There's nothing much we can do about it. But otherwise, in prescribed doses, these should not cause any unconsciousness. So now, these are the basics of moderate sedation. Now, if a question like conscious sedation comes, you have to answer it as moderate sedation. Then these, you have to answer it under these side headings. First, you have to talk about the definition of conscious sedation. Then you have to talk about the routes of administration. Then you have to talk about the drugs. And then you have to talk about specific guidelines for moderate sedation. So these should be your side headings when you answer any question on conscious sedation or moderate sedation. So first we'll take on the last point, the specific guidelines. So this is the reference for you. Here, there are specific guidelines which are given for moderate sedation in terms of personnel, infrastructure, and the monitoring which is required. So this is a guideline, the code guideline. I'll keep coming back to this guideline a lot of times during the course of this presentation. Definition, I've already told you. Coming to routes of administration, basically there are only 3 routes. To keep it simple for you, one is enteral, which makes use of the first bypass metabolism, and that includes oral or rectal. Then you have techniques which bypass the first pass metabolism. Those are the parenteral techniques, including intravenous, intramuscular, intranasal or submucosal. And then you have inhalational route, that is through which you administer nitrous oxide oxygen sedation. And when it comes to drugs, again, don't get confused because of so many drugs in literature. There are basically only 4 drugs for moderate sedation. One is sedative hypnotics. These are the drugs which act on the reticular activating system and put the child into sleep. All right. Those include chloral hydrate and triclophos. Then you have anti-anxiety agents, which are anxiolytics, which calm down the child in addition to making them a little drowsy. So they are anti-anxiety and sedative agents, under which you have benzodiazepines, hydroxyzine, diphenhydramine. Then you have narcotics. And you don't talk about morphine here, because the only narcotic which is used for moderate sedation is meperidine. That too, not as a primary drug. It is usually used as a secondary drug. And then you have the good old nitrous oxide oxygen. These are the only 4 drugs, categories of drugs that you need to remember. Now, I picked this up from a very classic reference. This book is a very well-known book. You know this book, Arthur J. Novak, 6th edition pediatric dentistry. And the chapter you have to go through is pain reaction control sedation. So it gives very nicely, it explains moderate sedation in a nutshell. And since you're hard pressed for time, if you want to understand moderate sedation, just go through this chapter, and this chapter will pretty much prepare you for the concepts on moderate sedation. Another commonly question asked in the exam is conscious sedation with benzodiazepines. This has been asked as a short answer. So for this, you have to first talk about advantages of benzodiazepines, and then you have to talk about mechanism of action of benzodiazepines, how they act on the GABA receptors. And then you talk about 3 benzodiazepines which are commonly used, that is midazolam, diazepam, and triazolam. Okay, so this will pretty much take care of this answer, and you'll get this from this another classic textbook, Behavior Management in Dentistry for Children, 2nd edition by G.Z. Wright. So I assume you may have already read this book, but for this specific question, I'm giving you this specific reference. So you need to go through pages 164 to 166. The chapter name is Minimal and Moderate Sedation Agents. This is one of my favorite topics, midazolam. So this has been asked as a short answer again a couple of times in various papers. So here you have to cover the answer under chemistry. What makes it water soluble? What are the pharmacokinetics of midazolam? That is what the body does to the drug. What are the pharmacodynamics and mechanism of action? That is what the drug does to the body. The routes of administration. This is a very versatile drug. You can use it through multiple routes of administration: IV, oral, intramuscular, intranasal, submucosal, any route. This is such a versatile drug. The various advantages of midazolam and the various complications that can take place when you abuse this or overdose this drug. All right. So this one, you can go through this. This is an old reference, but this is a classic reference by QPH Sky. That is midazolam, a review of its use for conscious sedation in children, given in 1993. Go through this article. This will pretty much tell you everything that you need to know about midazolam and pediatric dentistry. So now that's pretty much about moderate sedation. So like I told you, you are EGPG, so I don't need to go into nuts and bolts of moderate sedation. I've given you references. I've given you the most commonly asked questions. So once you understand the concept, you'll be able to answer any question on moderate sedation or conscious sedation, regardless of whichever permutation and combination they have been asked in. So now let's go to deep sedation and general anesthesia. First, I'll talk about the basics. So deep sedation and general anesthesia are a continuum. Terminology and definitions are only academic. In deep sedation, the anesthetist practically works in Goodell stage 1 of anesthesia or the ultra-light plane of general anesthesia. So dear students, you need to understand this concept very well, that deep sedation and general anesthesia are pretty much the same when it comes to clinics. All right, there's no difference when it comes to monitoring, or when it comes to infrastructure, or when it comes to the personnel. The requirements for deep sedation and general anesthesia are pretty much the same. So in deep sedation, the child is in a state where he's floating between semi-consciousness and unconsciousness, and practically he's in the ultralight plane of general anesthesia. So this is something you have to understand. It's a continuum. There's hardly any difference between the two. So in deep sedation, the child is practically unconscious unless a deeply painful stimulus occurs. So it is differentiated from general anesthesia in the sense, in general anesthesia is a state where the child is continually unconscious and unresponsive to any degree of painful stimuli. So practically, this is the only difference. Whereas in deep sedation, let's say the child is in deep sedation and you take a periosteal elevator and just poke it into his gingiva, the child may just open his eyes for briefly, he may open his eyes and again he'll go back and he'll drift back. Okay, the response is very weak. It's not a purposeful response. It's a very weak response. Whereas in general anesthesia, the only difference is even if you continuously keep poking, the child doesn't wake up. But clinically, the difference is, it's a continuum. There's very little difference clinically between the two, and that is something you have to understand. Another misconception among postgraduates is that IV sedation is equal to deep sedation, which is again not the case. IV sedation can be titrated to achieve moderate sedation or deep sedation, depending on the drug used. For example, if you use midazolam, you can titrate the child to moderate sedation using IV. Or if you use a drug like propofol in prescribed doses, it will lead the child into unconsciousness in very small dose, prescribed doses. So the route has got nothing to do with deep sedation. Okay, so in fact, deep sedation or general anesthesia can be achieved with any sedative drug or any route. For example, even if you give chloral hydrate orally in very high doses, that itself can lead to deep sedation or general anesthesia. So it's not the route which leads to deep sedation and general anesthesia. It is the drug that you use and the dosage that you use. So I hope this concept is also clear. General anesthesia is the loss of consciousness caused by the administration of drugs, regardless of the method of airway management. So the airway management can either be can either be with intubation, it can be with supraglottic devices like laryngeal mask airway, or it can be an open airway where only a throat pack is given and no sort of intubation or LMA is given. So this is again a concept that I want to clear for you PGs, because there's a misconception again that only if you intubate, that is general anesthesia, and suppose you don't intubate, it's an open airway, then it's considered sedation. This is very disturbing because many times on social media also I see some pediatric dentists have posted their cases, all with good intentions. I'm not blaming them, but it's a lack of understanding the concept. They post their cases wherein they show cases where an anesthetist is working in their clinic, and general this propofol ketamine unconsciousness has been induced by ketamine, and then it has been maintained with anything else, maybe fentanyl, propofol, or meperidine, and a nasal cannula has been inserted into the nose, and no intubation has been done. And they write that we completed this case under sedation. No, I'm sorry, that is not sedation. The child is under general anesthesia. All right. So just because the child is not intubated doesn't mean the child is not under general anesthesia. General anesthesia can be done even with an open airway. For example, the pediatric dentist and the anesthetist have to discuss. The pediatric dentist can tell the anesthetist that, look, I have a very short case. I'll finish it within 10 to 15 minutes max. I only have to do one pulpotomy, MTA pulpotomy, and then I have to push in a Hall's crown for the same tooth. So I'll be doing it under the rubber dam, and I'll use very minimal water from the aerator. I don't need intubation, because for that you'll have to take the child into very deep anesthesia by giving him succinylcholine, and the recovery is going to be prolonged. So I don't want that. So I want to do it without intubation. So the anesthetist will tell, fine. So as long as you're going to use minimal water, very short procedure, go ahead. We'll do it with an open airway. I'll try and assist ventilation through some other method. I'll bag the child, but you do it quickly. All right. So that is okay. That is a discussion between the pediatric dentist or the anesthetist. Or the pediatric dentist can tell the anesthetist, look, it's a very long procedure. Numerous teeth are to be treated. Many teeth are broken down. I may not be able to use a rubber dam also, and I'm going to use a lot of water. So it's better that you secure the airway for me using intubation. That's a discussion. Or he can just say it's an extraction to be done, but it may become a complicated extraction. I may break the root in between, so it may require an open method. So let's not take a risk. Let's not keep an open airway, but you can maybe insert a LMA, a laryngeal mask airway, and I'll try and finish the procedure as quickly as possible. So general anesthesia is basically a discussion between the pediatric dentist and the anesthetist, and it's got nothing to do with intubation being there or not. So I hope, again, I clarified this concept for PGs, because you need to understand this concept very well, because doing general anesthesia in the clinic is okay as long as you have the infrastructure, but not knowing that the child is under general anesthesia and assuming that the child is under sedation or not having adequate monitoring is where all the disasters happen. Okay, right. So another misconception is that if gases are not used and only IV drugs are used, then it is sedation. So this is again another misconception. So again, PGs assume that only if the Boyle's apparatus is used, then it is general anesthesia. If IV drugs are used, then it is sedation. No, it is wrong. General anesthesia can also be obtained by a technique called as TIVA technique, that is total intravenous anesthesia, where, if you read that chapter, working with a dental anesthesiologist in that GZ, right? The reference that I gave you previously, you'll understand that the dental anesthesiologist in the US, they come to the clinics and they use a TIVA technique, and they induce and maintain anesthesia completely with IV drugs. And that is also a known form of anesthesia. They may or may not use intubation is another issue altogether, but the fact that only IV drugs are used doesn't mean that the child is under sedation and not under general anesthesia. General anesthesia, deep sedation, is basically the level of unconsciousness. And I want you to understand that very well. It has got nothing to do with intubation used, or it's got nothing to do with whether gases only are used and the Boyle's apparatus is used. So students, I hope these concepts are very clear. So for you to understand these concepts really well, I'll give you 3 references. So you just need to go through these 3 references before your exam and you'll understand what I'm talking about. So the first reference is oral sedation procedures for oral sedation for dental procedures in children. And you read the chapter number 10, deep sedation and GA. So this book is available. Please get hold of this book and read this particular chapter. The second reference I want you to go through is, sorry, I didn't give you this reference. So this is a reference I'm giving you now. Again, behavior management in children, in dentistry for children, the second edition. So please go through that chapter, working with a dental anesthesiologist. Okay, so it's a very nice chapter for you to go through, second edition. And then please go through this classic book, Sedation by Melamed. Go through these 2 chapters, chapter 30, Fundamentals of General Anesthesia, and chapter 31, Armamentarium, Drugs and Techniques. Now, please note that I've given the reference as the 5th edition, not the 6th edition. The 6th edition is also available, but for some reason, the chapter on general anesthesia and armamentarium, drugs and techniques are not explained very well in edition 6. So I recommend edition 5 and these chapters, because as the new editions come in, they may completely eliminate it, and there's crucial information stored here in these 2 chapters. So please go through these 4 chapters and you'll completely understand the concept of deep sedation and general anesthesia. And then you'll be able to answer any question, like I told you, in any permutation or combination. You can answer them very, very easily. So let's take on a few questions that have been asked in the university exam on these topics. So there are 8 questions I've taken up, and it pretty much covers all the questions which have been asked in the university in various combinations. So the first question is, enumerate and describe drugs used in sedation and GA. So this has been asked as a long answer. So read the question well. It's been asked, enumerate and describe drugs used in sedation. They've not said deep sedation. So you have to enumerate even the moderate sedation drugs, and the reference I've given you earlier. Then enumerate the deep sedation drugs. See, I told you the moderate sedation and deep sedation drugs are different. So deep sedation drugs like ketamine, propofol, fentanyl, or analogs like remifentanil, even in prescribed doses, they lead the child very quickly into unconsciousness or near unconsciousness. So the drugs are different. So now you may understand the definition that you should use drugs which are very unlikely to cause unconsciousness. So deep sedation drugs and moderate sedation drugs are very different. And drugs used to achieve general anesthesia. Now, this is one flow of obtaining general anesthesia, but it varies with different anesthetists. Different anesthetists prefer different flows to obtain general anesthesia. So this is one flow. So first, the anesthetist pre-medicates the child with oral midazolam. Then induction is done IV through propofol, ketamine, fentanyl, or analogs like remifentanil. Then succinylcholine, once the child is unconscious, then succinylcholine is given to facilitate intubation. And then the anesthesia is maintained with sevoflurane or IV meperidine, and the anesthesia is maintained. So these are the common drugs for general anesthesia. So the reference for this, the moderate sedation, I've already given you the PINCAM reference. For deep sedation and general anesthesia, the 3 or the 4 references that I gave just before this slide, that is oral sedation book and the behavior management rights book and the 2 chapters from 5th edition of Melamed will pretty much give you whatever you want to know about this particular question, and it will help you answer this question very easily. All right. So another commonly asked question is ketamine, and it's been asked very frequently as a short answer. So the reference to this particular question is go through the chapter Intramuscular Sedation, again in Melamed, 5th edition, page number 154. And you also have to go through the chapter called as Pharmacology and IV Sedation. That is chapter number 25 in, again, the 5th edition of Melamed, the page numbers 344 and 345. So see, your exam going, so I don't want to put you under too much pressure. So I'm giving you very specific references, including the page numbers. So these are small pages that you need to read, and you'll get the answers to these questions. So the concepts, if you go through the references that I gave you, you'll be able to very easily answer questions on deep sedation and general anesthesia and moderate sedation. Some questions like this need specific references, and I'm giving you specific references for those questions. So let's see, what's the third question? It's given: differentiate conscious sedation, deep sedation, and general anesthesia. Give their indications and contraindications in pediatric patient undergoing dental treatment. So this has been asked as a long answer. So I think the first part disappeared under my, yeah. So the first part, you have to differentiate conscious sedation, deep sedation, and general anesthesia. So you have to define all the three kinds of sedation. And let's see, okay. Yeah. Then to differentiate between the three forms of sedation, first you differentiate, what you do is differentiate between moderate sedation and then club deep sedation and general anesthesia together, because I told you there's no much difference between deep sedation and general anesthesia. Okay, so you can club these two together and differentiate it from moderate sedation. So the reference is again the quote reference, that is the APD reference, E26 to E52. So what you can do is you can go to table number 2 in that particular reference, and they're very nicely differentiated between moderate sedation and deep sedation general anesthesia. So you can go through that. And let's see, yeah, let's go to the second part of the question. So the second part of the question says, give their indications and contraindications in a pediatric patient undergoing dental treatment. So here again, I'll explain the concept to you. So I think this is blocking it. So I'll just bring it down. Yeah. So just to understand the concept to you, we'll minimize this as well. Can I? No, I can't. So I'll bring this down. So just to understand the concept to you, so give their indications. So I'll give you the indications between moderate sedation, deep sedation, GA and GA. So moderate sedation, this is usually handled by a pediatric dentist along with a pediatric dentist along with a monitoring personnel, a trained monitoring personnel. So the indication for moderate sedation is basically anxious children, that is Frankel positive and negative children. So moderate sedation, dear students, please note this, moderate sedation is not useful for combative children or disruptive children or children displaying uncontrolled behavior. All right, the drugs which should be used like midazolam, the drugs along with basic behavior guide anxious child cope up with the procedure. So please understand this. Moderate sedation on their own, the drugs are not powerful enough for them to override the coping abilities of the child. So the drugs are to be used along with basic behavior guidance techniques and with good painless local anesthetic techniques, which helps the anxious child. Remember the word anxious child cope up with the procedure. So it's not useful in combative or disruptive children. So what is the indication for deep sedation or GA with an open airway? When do you do this? So this is to be done along with a pediatric dentist and with an anesthetist. Please note that I've again clubbed deep sedation and GA, but I've used the word open airway. So this is used for Frankel's definitely negative children, the ones which are combative and disruptive. where all the required treatment can be completed in a single 15 to 20-minute appointment with minimal use of water and with a rubber dam. So for one child, let's say everything else is healthy, there's one deep carious lesion, but the child is extremely disruptive. Don't even bother using moderate sedation. It's not going to work. All right. So in such cases, you may have to go for deep sedation GA. But if you don't want to intubate the child, so you can go for deep sedation here along with an anesthetist. Discuss it with an anesthetist that it's a short procedure. I'll finish it within 15 minutes. Okay, I'll use a rubber dam. I'll use water very minimally so that it doesn't get into his throat and cause any laryngospasm. And the anesthetist will help you with any other mode of assisting ventilation, like bagging the child. All right. Okay, so this is something very important you have to understand. And the third one is general anesthesia along with intubation. See, I've differentiated that deep sedation GA with an open airway and general anesthesia along with intubation. This is again done with the pediatric dentist and anesthetist, which is done in Frankel's definitely negative children, combative, uncontrolled behavior. Okay, these kind of children, disruptive children, where the child has got extensive treatment needs. So I hope you understand the indications very well. Please note here that for deep sedation GA or GA along with intubation, I've not said that compulsorily you have to do it in the hospital. No, you don't have to. If your clinic has got sufficient infrastructure, monitoring, there's a recovery room, you got all the good monitoring devices, the anesthetist is also there, all the infrastructure is there. There's no contraindication to giving GA even with intubation in your clinic, but you should have, it should be on par with an OT. Okay, if you can do that, in US they do it very often. They invite the anesthesiologist and do it in their clinic. But in India, conventionally, we do it in the theater because in India because in the US, taking the child to an operation theater and hospital is very, 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 very expensive. That's why they have worked out this jugaad in the US. Okay, wherein in India, we don't have to do that because the hospitals may not be that expensive compared to you doing it in the clinic and the big investment that you require in your clinic. So we do it in the hospital. All right, but I want you to understand this concept very well. So don't do deep sedation and practically the child is unconscious and in GA, and then don't claim that you've done it under sedation. You're taking a grave risk. All right. Okay. So now coming to the reference. So how to answer these questions? I'll take these two guys up again. Yeah. So for indications and contraindications for sedation and general anesthesia, please go through this reference. Again, the APD reference, not the court reference. This is a different reference. It's another chapter, behavior guidance for the pediatric dental patient. And the pages that you need to read are 301 and 302. All right. The fourth question, which has been asked, define sedation. Discuss the goals of sedation as defined by AAPD guidelines and name the emergency drugs that may be needed to rescue a sedated child patient. So this has been asked as a long answer. So define sedation, you already know the reference. So for goals of sedation, you can again go through the behavior guidance chapter in AAPD manual. The page number is 301. And for emergency drugs, you should go through these two references, the court reference and the emergency drugs and equipment. There's another chapter 33, again in Melamate, 5th edition. So I like the 5th edition more compared to the 6th edition. So if you get hold of it, if required, buy it. But then keep it with you, because with the new references, with the new editions, this may just phase out. All right, it's a beautiful book. So we'll go to question number 5. ASA classification system for GA. This has been asked as a short answer. This has got many references, but I prefer this particular reference. Again, don't bother, it's gone above, but that's again the court reference. All right. So go to Appendix 2. So the difference in this particular reference is that if you read the last line, This has been modified to give common pediatric examples. So this explains ASA system as it relates to pediatric dentistry very well. So please go through this. Fairly simple, very easy to understand for you EGPGs. Another question which has been asked, pre-medication in pediatric dentistry, which has been asked as a short answer. It has also been asked as role of pre-medication in pediatric patients, again as a short answer. So the misconception is that pre-medication is related only to GA. No, pre-medication is a different concept. So pre-medication has got numerous uses. One of the uses is it can be used as an anxiolytic before a dental procedure for a good night's sleep, especially in adults. It can be used as for sedation before induction of GA. Like I told you, you can give oral midazolam before GA induction. It can be used to provide anterograde amnesia to the child so that the child does not remember what has happened. So it can be used for that purpose. It can be used to prevent post-operative vomiting. You can give an ondansetron right in the beginning to prevent any post-operative vomiting, or if the child has got a heavy gag reflex. It can be used for preemptive analgesia. This is commonly used in oral surgery where analgesic is given about 1 hour before the extraction, so that after the extraction is over, the effect has already started taking place, the effect of the analgesic. And it can be used to facilitate the exception of the nasal hood in Frankel's negative children. So Frankel's negative children are what Dr. Sharad spoke about yesterday, the whining children classically. So they won't accept the nasal hood. They'll keep moving their head this side and that side and they'll whine. So you can give a little bit of oral midazolam and then they calm down and then it's easy to communicate and then you can give them the nasal hood. And these children then accept the nasal hood pretty sportingly. So the reference for this is Padmanabhan and Muthu and Sivakumar. The book, the textbook, Pediatric Dentistry, the chapter is Pharmacological Behavior Management. All right, so now this question has been asked. This is a very easy question to ask. So whatever I've discussed till now, you can put everything into this answer, pharmacological management, 100 marks, you can just go berserk. Very easy to answer. The last question, the 8th question, this question, it says conscious sedation versus general sedation in pediatric dentistry. This has been asked as a short answer. So this is basically what you call as a bouncer in cricket. It is a bouncer because an unscientific terminology has been used. We know what is conscious sedation, but I don't know what is general sedation. There's no scientific terminology called general sedation. So probably what the examiner meant was conscious sedation versus deep sedation. So that is what I assume. So if you get a bouncer like this, now that you have understood the basics really well, you can assume that this is the answer. So you don't have to duck it like this batsman. You can in fact hook it for a 6, isn't it? All right. So that's the end of my 8 questions, dear students. So before I wrap up this presentation, I'll give you a couple of exam tips. So important exam tip is about writing the theory paper. So I'll give you an analogy. For example, writing your theory paper is like you taking part in a cooking competition or a culinary competition. So let's say you're taking part in a cooking competition, and if you prepare a very delicious dish, but which has been presented very badly, it is a very ugly looking dish, but it is delicious. You know it's delicious, but you presented it very badly. How do you think the head chef or the judge of the competition will react to it? He'll be very annoyed and he won't even bother tasting your dish, and he'll dismiss you from the competition, or he'll just give you very, very less marks. The same happens with your theory paper. So assume you have written an answer in your theory paper where you have given beautiful information, very, very good information, but you presented it very, very shabbily, very, very bad handwriting, illegible. So you're just going to end up with a very, very irritated examiner. Okay, so this is what happens. So that is why, dear students, so I'll give you some exam tips here for your theory paper. Structure the answer if possible. So if you know the answer to a question very well, leave a little space, half a page, you leave it. Then you write the answer under various side headings very nicely, then transfer those side headings into that space that you're left. So when the examiner opens your paper, he sees that you have structure, given contents upfront. So immediately he'll come to know the student knows the concept. Okay, so you'll easily end up with a few marks more compared to the other student. Underline important points. Suppose you've put in a clinical study, you have given a clinical tip. How will the examiner know? Underline that point. Draw margins. We were taught this in elementary school, isn't it? Draw the margin on the left side and on the top. But we don't draw it now. But it improves the presentation of your paper tremendously. It tells the examiner that this student wants to, write a good theory paper. So he'll take you more seriously. All right. So draw margins. Write legibly. All right. My father is a medical practitioner for over 50 years. And all his patients take his prescriptions only to one pharmacist, because legend has it that only that pharmacist can decipher his handwriting. So the patients don't want to take a risk. They all go to one pharmacist. But he is a doctor with 50 years of experience. He can afford to have a bad handwriting. As EGPGs, you can't have a bad handwriting. Okay, so you don't have to have a brilliant, neat handwriting, but at least write legibly. All right. Okay. And draw diagrams. Please draw diagrams. Schematic diagrams again tell the examiner that this student has understood the concept, and he may not even read. Just by seeing the diagram, he may give you maximum marks possible there. All right, but my disclaimer is draw diagrams only where necessary. For example, one of the PG papers I corrected about, I think about 7-8 years back. The question yesterday, Dr. Sharad discussed, the question was different types of cry. And the student had actually drawn different types of, cry. You can't argue with the sentiment of the student, but this was, completely unnecessary. All right, so draw schematic diagrams to explain a concept, but don't draw diagrams simply or unnecessarily. Like don't draw diagrams for modeling and tell show do. It doesn't make sense. All right. Okay, so that's about it. So dear students, that's the end of my presentation. The last couple of years have been very difficult for all of us, especially for you, the exam going PGs. I understand this is a very difficult time because there's so much uncertainty and you have to prepare for your exams amongst, amidst so much uncertainty, and it's very difficult for you guys, I understand. But then, the best way forward to handle any challenge in life is to have a positive outlook. And, the truth is that every dark cloud will have a silver lining. So, dear students, I sincerely pray and hope that all of you, do really, really well in your exams and pass the exam with flying colors, so that you remember 2020 and 2021 not as bad years or difficult years or unfortunate years, but I want you to pass, do well, and I want you to look back on 2020 and 2021 long after this pandemic is over. I want you to look back on these 2 years as the years that you passed, you took up all the challenges, and in spite of the difficulty, you went on to become pediatric dentists, the batch of 2021. So dear students, wishing you all the best for your exams. May God bless all of you. Thank you so much. So I hope I'm within my time limit. Yeah, it's 44 minutes. So thank you so much, dear students.
Thank you, Dr. Ashwin, for your excellent review class as expected.
Thank you so much.
I got to listen to the students. See why he has come out with flying colors. The first best PG, utilize his tips and go ahead. I hope the PGs will be benefited from this revision. Now I wanted Dr. Varghese Chacko to come in and.
Yeah. So far, no questions in the chat box. I don't see any questions. Thank you again, Ashwin, for your presentation. It was excellent. I think you have given very, very valuable tips. Okay, you have made it very easy for the PGs, telling the exact textbook, exact page number. Thank you very much.
Thank you. Thank you. Thank you.
So far, no questions. Everybody, there are comments saying excellent presentation. I think you can see them too.
Thank you, students. Thank you. I hope it didn't go above your head. It's a slightly difficult concept, but I hope I was able to simplify it for you.
Okay, I think, Anandaraj, I can give a concluding remark, I think. I think nobody is having no doubts, sir. It was an excellent to a PG, how you have to do it. I think he has utilized, I'll tell in the concluding remark one more point actually. Okay, Ashwin, very good.
Yeah,
Thank you so much. Thank you so much.
Okay,
Thank you, sir.
To all postgraduate students, I just wanted to tell 2-3 points. Only few days or months remaining for your PG life to end. I just want to tell you, make use of it completely. When you're going to write a postgraduate exam, be serious. My only advice to all exam going students is to quote as many references. He has gone, Ashwin has given you some tips, but in that also, I just want a little more the same academic thing. You quote as many references as possible in each answers. Even you can go for try for flow chart in essays and impress the examiners. He has told some points, but I am adding little bit this thing. And actually, this is lacking in nowadays MDS exam papers, answer papers. That's why I'm insisting on that. Anyway, few revisions are coming. By Kavita, she will be taking how to write an essay and short question. It is coming, I think, in the next few weeks. Then Subbalakshmi is giving you how to prepare MDS exam and time management. Very, very important, time management. Then one more point I just wanted to tell all exam going people, don't get tense, which will be affecting your performances. Because this one I have seen in many cases, very good students getting tensed and the performance is coming down. So I'm giving you best wishes to all exam going students, expecting a good performances from you all. Do well, God bless. Thank you. Also, I thank Dr. Anandaraj and Dr. Suprasit for giving me this task. And not the last, thank you, Varghese Chacko, for moderating this session. Thank you all.
So there are a couple of questions now that have come in. May I ask?
Then,
Ashwin, one question that has come is, which drug do you prefer for moderate sedation in a 5-year-old child with, he's written amnesia, I'm not sure about that. Which drug do you prefer for moderate sedation?
Yeah, I think what the student meant is to produce retrograde amnesia in a child. Which moderate sedation drug? So it's a good question. So in a child, again, I emphasize use moderate sedation only when the child is anxious, not a combative child. So in such a case, to produce anterograde amnesia, there's no better drug than midazolam. In fact, I'll go as far as to say that in pediatric dentistry, I feel, that's my personal opinion, sometimes you unnecessarily complicate by, discussing too many drugs. Clinically for us, there are 2 drugs which work great, either in isolation or in combination, depending on the indications, that is midazolam and nitrous oxide oxygen sedation. Because I believe that finally, you should use drugs for which purpose they were manufactured. For example, midazolam has been manufactured for sedation. It's its primary action. So why would we want to go for something like hydroxyzin or meperidine, whose primary actions are not sedation? Their secondary actions are sedation. To get a sedative action, they have to be given in much higher doses. Only then its secondary actions get activated. So I feel, to answer your question more directly now, close your eyes and go with midazolam.
There's one more question. Which drug is advisable for retrieval from moderate sedation? Yeah,
so like I told you, I prefer to use midazolam for moderate sedation with or without nitrous oxide sedation. So when I use midazolam, there's a beautiful drug, flumazenil, which can be used for retrieval. But the truth is, you will never if you have not abused midazolam, midazolam will never reach that state wherein you need to, give a flumazenil. Even if some desaturation is there, just waking up the child and calling out his name will take care. Or maximum, you may have to just suction and you may have to just do a head tilt chin lift, and that will take care of it. But for academic purposes, if you're asking me, flumazenil is the drug. It is prescribed that it should be given only IV, 0.01 milligram per kg body weight. But the truth again is, in clinics, pediatric dentists on a regular, I really feel that's a skill set that should be included in the pediatric dentistry course, learning to give, starting an IV line. But since we don't do it regularly, we can't just, give an emergency drug IV when the child is going through an emergency. So flumazenil, this is not given. This is given in that oral sedation book, that it can also be given IM into the vastus lateralis muscle if required, at a much higher dose of 1 milligram. I hope I answered your question.
Thank you, Ashwin.
It is over, right?
Yeah, that's all. Only 2 questions. Yes.
Anyway, thank you all for your
Thank you. Yes.
Thank you, sir. Thank you. It's a pleasure, sir. Thank you.
Thank you, sir.
Thank you, Ashwin sir, for that concise presentation and the tips for the exam going PGs. I thank our moderators also for moderating the sessions. That is Dr. Suresh Kumar sir and Dr. Varghese Chacko for moderating the session. Thank you all. So see you on next Saturday at 7 p.m. Thank you and good night.
Thank you.